My name is Mattias Götberg. I work as an interventional cardiologist at Skåne University Hospital in Sweden. Today with me I have Ted Feldman, who works at Evanston Hospital in Chicago, and Lars Sondergaard, who works at Rikshospitalet in Denmark. So, Ted, congratulations to the presentation of REPRISE III trial. It's truly a marvelous trial. So could you give the audience a little bit on the background of the REPRISE III trial?
Sure, and I appreciate the congratulations because we had a large group of people, a huge group of investigators working for several years to reach this primary endpoint of the REPRISE III trial. This is a 912 patient randomized comparison of the first generation Lotus valve with core valve in a high and extreme risk patient population. And I think it's really critical to emphasize that it's a high risk trial when we think about the results.
So what about the results? Can you tell us about the primary endpoint?
We did a safety and effectiveness trial, and this is a FDA approval trial. The primary safety endpoint was 30-day all-cause mortality, total stroke, major bleeding, vascular injury, and acute kidney injury. And the analysis group was implanted patients, those that received the assigned valve. And we found no difference at all, no significant difference between Lotus and core valve. And in fact, if you look at a Kaplan-Meier curve between time zero, you see the 30 days all the way out to a year. The lines for the composite endpoint for safety overlap. So we defined non-inferiority for safety. The primary efficacy endpoint is all-cause mortality, disabling stroke, and moderate or severe paravalvular leak at 1 year, also in the implanted group. And we found that the Lotus valve was, in the first analysis, non-inferior, and then with the pre-specified superiority analysis, also superior for that composite compared to the Lotus valve. This was clearly driven by paravalvular leak primarily, but there was also a difference in disabling stroke favoring the Lotus valve.
So yeah, the stroke was actually a very interesting finding, because my only concern was that if you give practitioners a repositionable TAVI device, which they can move back and forth until they're happy with it, with the position when they release it, I think that in my mind there would be an increased risk of stroke, and actually quite the opposite was seen. Do you know why this occurred? Well,
I'm not sure we can say the whys out of a trial like this, but it's clear, one thing is clear, that is that the 3.6% disabling stroke rate at a year seen in the Lotus group is in line and actually at the lower end of major stroke rates in high-risk patient trials. And I think this is where some people get a little confused with remembering how low the intermediate risk trial stroke numbers are. But when you really look at the high-risk groups, the Lotus group had a low disabling stroke rate, and to your point, there was not a penalty for repositioning.
So Pacemaker was something that stood out among the results as well. Could you tell us about the pacemaker dependency?
Indeed, the pacemaker rate was one of the other endpoints. It was not part of the primary endpoint, and part of the reason for that is that in high-risk populations there hasn't been a mortality penalty for new permanent pacemakers. And I don't mean to minimize the impact, but it's still at a different level than death, stroke, and paravalvular leak. But we saw a greater than 30% pacing rate in the Lotus group compared to a sub 20% pacing rate in the core valve group. We are aware very much that the Lotus valve, because it shortens from both ends to the middle, interacts with the left ventricular outflow tract a great deal. I think Lars will talk a little bit as we go further about design enhancements that might change this, but I would throw it back to you as an experienced Lotus operator and ask what you think when you see the rate of 35% based on your experience.
Well, I think it's pretty high. I mean, we have noticed that REPRISE I, II extension, now REPRISE III trial, but also Respond registry, we've seen consistently pacemaker rates about 30%. So this is something that really stands out with Lotus device. With that said, I think it's fair to say that it's dependent on implantation technique as well. We know that if we are able to position the valve differently, we get different pacing rates, and this is something that we have replicated. When we started off with the initial implantation technique, we found a higher pacing rate, but then we started implanting higher, and our pacing rate lowered, and we're in the region of below 15% consistently now, despite looking new techniques, having new operators. So I think that we can pretty much cut the pacemaker rates that were observed in trials by half, and this is also mirrored by large study by the Nordic Registry and other large cohorts as well. So, Lars, back to you. Could you comment on the pacing rates as well and your experience with this, but also with the future generations of the TAVI device, and if that means an improvement in pacing rates as well?
I mean, pacemaker rates has been high in TAVI compared to surgical aortic valve replacement. And I think today it's recognized that if you implant too deep, if you interfere in the left ventricular outflow tract, you have a higher risk of conduction abnormality and the need for a permanent pacemaker. And as you mentioned, it's been pretty high with the current generation of the Lotus valve. Better implantation technique had brought it down. And we have now seen that the next generation is coming out, the Lotus Edge, which have several features. One of them is what we call the depth guard. So it's changed the way the valve actually deploys. It's coming out like a tube, and with the current generation, it foreshortened from both ends, both from the aortic end and from the left ventricular end. So there was some interfering with the bundle branch block, which could partly explain the high pacemaker rate. The new generation is mostly foreshortening from the top part, from the aortic side, so it doesn't dive as deep into the left ventricular outflow tract. And that's for sure give us a hope that we'll see a lower rate of permanent pacemaker with the new depth guard. And we have seen the initial results. It's not a lot of patients, but still 50 patients, and in several sites, it's less than 20% of pacemaker rate at discharge. So I think it's for sure, in combination with better implantation technique, is going to bring it down to a very comparable number with the other valves.
Yeah, I fully, like we said, what's left now is looking at and focusing on the new pacing rates to make them come down to what we actually see in the clinical. And being one of the proctors for the REPRISE III trial, we had to proctor the classic method as well. So I think that from my perspective, I think that having the Lotus Edge together with depth guard, which we had a very good experience after changing the implantation technique, I think that we consistently are going to see a lower pacing rate. But this, of course, has to be confirmed, and we are conducting registries after the launch of the Lotus Edge as well to look at this.
Well, I think it's especially important as we look forward, as we're planning REPRISE IV in intermediate risk patients and REPRISE V in low risk patients. Two things that we're thinking about hard. And on the positive side, it's not only that we have a low, moderate, severe PVL rate in REPRISE III, but that we have a better than 85% rate of none or trace PVL, so that we're really eliminating PVL as a clinical feature of the platform, but also that I think we're working hard on getting the pacing rates down as we move into these lower risk cohorts.
Yeah, so I think that what comes next is probably a joint effort than trying to get a more coherent way of implanting the Lotus device or the Lotus Edge device, and then teaching that consistently as well, because as we move down into younger patient and low risk patients, the pacing rates are going to be increasingly more important as well. But other than that, the overall clinical data, and especially the best-in-class PVL rates, are something that's really an advantage with this device. So, thank you very much. If I may summarize, we've been looking at the REPRISE III trial and the Lotus and next generation Lotus Edge device as well. The REPRISE III trial found that the Lotus valve was non-inferior to the core valve and valvular in terms of the primary safety endpoint, but also that it was superior to core valve and valvular in terms of the primary efficacy endpoints. Pacing rates were high, but as we've discussed today, we have ways both from a mechanical point of view, but also an implantation point of view of lowering the pacing rates. And I guess further studies such as the REPRISE IV and REPRISE V trials, but also the registers will find out if these changes to implantation technique, but also to the design of the valve, would lower the pacing rates. Thank you very much.
Thanks.